So I will quickly introduce our presenter for today, who is in the person of Dr. Aditya Kasarabada. Aditya is the Interim Systems Director for Medical Critical Care for the Inova Health Systems, which is located in Virginia, USA. He completed his medical training at the Armed Forces Medical College in India, with residency in Medical College of Wisconsin and fellowship in pulmonary and critical care medicine at the Drexel University. Since training, he supported the training of medical students, residents, and fellows in a large academic veterinary care centers in Philadelphia and in Virginia. He previously served as the Regional Director for Medical Critical Care at Inova. In addition, he served as the Director of Bronchoscopy and Endoscopic Services and Director of Respiratory Services at the Henneman University Hospital in Philadelphia. Dr. Kasarabada's focus is on using a Center of Excellence approach for quality service delivery and integrating data-driven, evidence-based practices. He has demonstrated success in working with multidisciplinary teams to implement system-wide improvements and human resource training. He has expertise in clinical quality improvement, focusing on the management of patients with critical acute hypoxia. He has a master's in public health from Emory University, focusing on epidemiology, and an MBA for Darden School of Business, University of Virginia. His expertise is at the intersection of pulmonary critical care, data-driven service delivery, and clinical operations. Dr. Kasarabada will be talking to us about fluids in intensive care units. We are very happy to have him join us and our fellows and others who join us for today's meeting. Dr. Kasarabada, over to you, please.
Thank you, Chris, Dr. That was a great introduction. I hope I can live up to everything that Dr. O said. Also, for me, it's a huge honor to sort of kick off the Global Critical Care Fellow Seminar Series. You guys are gonna hear some fantastic speakers through the course of this series. So this is actually great that I get to kick off. So no pressure at all. The bar is gonna be pretty. Well, at least I'm setting the bar. So we'll see how this goes. Just can I start sharing my slide? I think I can. Let me start sharing. All right, can you guys see my screen?
Yep, it looks good.
Okay. All right, so we're gonna start off with the talk about fluids in the ICU. To kick off the global the seminar series that is there. So I have no conflicts. Can you guys see my cursor by any chance?
Yes, we can see it.
Okay, good. So I have no conflicts towards this talk. So basically what we're going to try and do is understand various types of fluids that can be used for resuscitation, the key differences between saline and balanced fluids, and important literature about fluid selection in the ICU. And these are some of the learning objectives for the talk. Now, I want to sort of pause here for a second and say a few things. We have a slide also about this, but fluids in the ICU or fluid resuscitation in the ICU depends on a couple of things. One is the volume of fluid that is being given and the type of fluids that is being given. This talk is primarily focused on the type of fluids that is being given because fluids, as I will show you, should be considered as an IV medication, not just something that we give in the ICUs. There is a talk later in this series which sort of deals with more about the types of deals with more about resuscitation, how to resuscitate, what targets you go after. So there is a talk coming about that, and I sort of wanted to focus this talk more in terms of the actual fluids that is there. Um, this lecture is supposed to be the way this was asked of us was like to create a lecture which incorporates the best of the evidence that is around, with also like points to sort of consider about like I think the discussion will be focused on how do you want to apply it to your specific scenario. To be fair, I have never been in Africa. My wife does a lot of work there, and so we're kind of trying to look up and see what kind of fluids are available. And I was pleasantly surprised that all of the fluids that we're talking about are actually available in the African context. There are actually now some guidelines in place already in certain countries, which talks about fluid selections too. So I think this will be a good sort of topic to start off with, to get an understanding of where the science is and where the science is evolving, and to see about just to think about fluids slightly differently in your patient context as well. Okay, with that in mind, let's get started. So we're going to look at a brief case. We're going to look through a little bit of the history of IV fluids because I think that's important, and plus I like history a lot. We'll do a little bit of a literature review about a brief overview about it because the literature is quite exhaustive, and then we'll sort of come towards the end about like what a few take-home points from there can be. Okay, so let's start with the case. So this is a 40-year-old diabetic who presents with progressive shortness of breath over the last 2 days. It's associated with fever, chills, productive cough. In the ER, his vitals were blood pressure was 76/40 with a heart rate of 122. He had a high respiratory rate. He was desatting on 100% non-rebreather. The patient was intubated and resuscitated in the ER. He was 80 kilos tall. His initial ABG is there 726, 44, 60, and 20. So you give antibiotics, you draw cultures, you intubated the patient. How would you actually resuscitate the fluids? And so I've put like almost like a standard-ish chemistry that you would normally see when a patient who comes in with septic shock is there, and his initial lactate was about 5. Chest X-ray is there. Can you guys see the X-rays? Hopefully this image presents well, but there's diffuse sort of infiltrates and opacities everywhere, and you can see a nice ET tube sitting right there. All right, so your options. Are you gonna give him 2 liters of saline and start pressors, or are you gonna give 2 liters of plasmolite and start pressors, or just straight away start pressors for this patient? Or you'll do 2 liters of saline followed by look at the IVC collapsibility or pulse pressure variability, and then as more fluids if needed, or vasopressors, or you'll do the same with plasmolite. So I would like you guys to sort of think about those options for a second, and we'll go through some of this later in the case about what actually happens with this case. Okay. So again, just so we're clear about what we're talking, we're going to talk about types of fluids. So more about how much and what to give, that's being covered in an entirely different talk. So let's talk about history. Okay, so this is in the developed countries. This is the most common intervention to a hospitalized patient. It's more common than oxygen. Like, I mean, you can ask any one of us, like literally, if you go to the hospital, the first thing that happens while you're even telling what is going on with you is like they will be sticking an IV in there, and somebody will be hanging some IV fluids for you. And the second thing that ends up happening then somebody will slap some oxygen onto you too. But if you actually look back at it, the first origins of it can be traced back to 1831, so almost 200 years ago in the cholera epidemic in England. So Thomas Latta and O'Shaughnessy, they pioneered that IV fluids for the treatment of cholera because they were like, well, these patients are getting dehydrated. And they sort of tried to look at the concentration of the liquid that was coming out, like the diarrhea that was coming out, and they tried to figure out what the patients were starting to lack, and they sort of created a fluid that they could give the patients at that point. And so this is the actual quote that they had. 2 drachms of muriate, 2 scruples of carbonate of soda, and to 60 ounces of water. But if you actually convert that to sort of regular speak that we do now, you'll see the start of the IV fluids, the current composition of sodium chloride, sodium carbonate, sodium bicarbonate, some potassium in it. Those start to show up in the IV fluids. So this is back in 1831. Fluids have had a lot of iteration to it. The Lata solution, the first one is what I told you about, and then he started to slowly evolve it. But by the time he got to the fourth solution, look at this. The modern equivalents of what he had were 134 millimoles of sodium and 118 of chloride and 16 of bicarb. This is starting to resemble what your normal electrolytes would look like. Further evolution is there. By 1883, Ringer's lactate came across, which is still the same concentration of what we do use today. And we'll talk about Ringer's lactate later in the talk too. And then they kept evolving, and somewhere along the line, in around like 1900s, close to that, sodium chloride became there. And now look, the concentrations are what we know of, right? 154 millimoles of sodium and 154 millimoles of chloride in it. So in 1888 was the first recorded use of the word saline, normal saline, but the concentration was not mentioned. And Hamburger thought to have made the first 0.9 normal saline around that time. So if you look back, so by the way, this is all from a article which I've referenced in the first one. It's called The History of 0.9 Normal Saline. It's a freely available article on Google. It's actually a pretty interesting read when you go through it. So one of the things that was mentioned in there was like one of the first articles that came about fluid was the majority of warm-blooded animals, including man, was isotonic to saline of 0.9% concentration. This is it. That was the scientific evidence used to support the general use of IV fluids back then. Remember, the easiest thing to do is take water, take salt, mix it in. Now you have saline, and that's how it became such a common fluid. But in 1910, Thies already pointed out that you only need about close to 2 grams of salt per day, and when you give 3 liters of saline, you're going way past that to almost 3 grams of salt. And so that he was like, started to mention that this can cause edema. This could actually potentially be harmful. So I do this to our fellows here, right? And so whenever they say about saline and just like randomly using saline, I'll show them this picture and say like, well, if you look at a bag of saline, right, the amount of salt that is there in it is equal to 50 bags of chips. Now these look like the larger chip bags, but there's a slightly smaller one, but it's still 50 bags of chip. If I asked you if there's a patient who came in with anything, right? I would say anything, but also let's just say heart failure. Would you actually let any one of your patients eat 50 bags of chips? In fact, I would say, even if I wanted to eat 50 bags of chips right now, I don't think I'll be able to do it. But that's generally what we are talking about here. Right, so perceptions aside, let's look at some of the literature that is available about fluids. So I'm going to show the slide and we'll come back to this towards the end of the talk. This is a review article in New England Journal from 2013, so almost like 10 years ago, which is titled Resuscitation Fluids, which gives like some general overview points about things to consider. Now, this was in 2013, and I'll show you data after that, but I think this is a good sort of slide to keep in mind, and then I'll come back to this towards the end of it to go over some of the points on this. All right. So these are the various types of fluids that are generally available, from saline, which is, sorry, here we go. From saline, which is the very first one, to plasmolite, which is a balanced fluid that is there, to albumin, to starch, to half normal saline, all that is there. Couple of things to keep in mind is look at when we say balanced versus not balanced, right? Like, so saline is pH is 5, and the electrolytes is just sodium and chloride, but the others start to have more concentrations of other electrolytes in it. So a little bit of potassium, a little bit of bicarb, depending on the type of solution that you're using. As I mentioned earlier in the talk, at the start of the talk, these fluids are available in the context of Africa. That's why I continue to sort of go along this pathway of this talk. They they may not be available in your specific institution. They may not be available in your specific institution, but it's good to understand what is out there and how the science is evolving, just so that you get a sense of what we can or what we can or cannot offer our patients. Okay. So we all talk about fluid resuscitation, then volume expansion, right? So this is a study from about 50 years ago in 1976 where they used a tracer and gave patients serially, they gave them dextran, hydroxyethyl starch or hespan, albumin, and just saline. And so if you notice, and each of it was about a liter of it was given, and then they measured what the volume expansion was in 1 hour. So if you look at it, the best was obviously dextran, right? So it's almost like 800 cc's of volume expansion happened if you gave a liter. If you keep going down all the way down, the lowest one is saline, or let's just call it fluids for now, but the lowest one is saline. But so what that sort of tells you is like, well, look, saline is not an efficient volume expander, right? So why do we keep doing this, and why is it not apparent in trials? Now, there's been a lot of trials, and I'm not going to go over all of them. I'm going to go over like probably like a select for like 15 out of those trials. But this concept that I'm saying is not necessarily apparent in trial, right? Also, think about it, what you're actually doing. We never give saline in context like, okay, I have to resuscitate somebody, 453 mLs of fluid, so I'm going to give that much, right? You always say in whole numbers, and usually for some reason that is not known, we all do it the same way. We'll give either a 500 bolus or 1,000 bolus or or 2 liters bolus, or like we talk in whole numbers in terms of 500. So then the actual effect, the differential effect between a fluid like dextran and saline is actually lost, because you are talking in large numbers, and so these effects sort of is not as apparent in studies. Talking about studies, the study that gets quoted a lot is called the SAFE trial. So basically, in this trial, in Australia and New Zealand, what they did was they took about 7,000 patients and randomized them between albumin and saline. And so the primary outcome was death. And so if you look at the Kaplan-Meier curve, there's literally no difference between saline and albumin. So the way the study got sort of promoted a lot about was like, so instead of saying there's no difference between albumin and saline, it sort of became this notion that there is no difference in outcomes between colloids and crystalloids. And we'll sort of look into that in a second. But like that was the big takeaway point from about it, that you could give albumin, you could give saline. It was the same. It didn't matter. So why not let's choose something that is less expensive for our patients? And so the IV, the crystalloid sort of came to fore at that point, because that was considered the major difference between colloids and crystalloids was the actual expense that was associated and availability that was associated with, say, albumin versus crystalloid. Okay. Now, when you look at the Kaplan-Meier curves and also the patients that were there, you'll find something interesting here already start to happen. So if you look at that, there were two subgroups, the three subgroups that I'd say ARDS, nothing changed. But in trauma, if you look at it, saline was far better than it was in than albumin. In fact, if you actually gave albumin, you had worse outcomes, as is clear from this chart. And there were further studies along the way which sort of pointed that out, and which is one of the recommendations is not to use albumin in patients with traumatic brain injury. But that sort of came about from a subgroup analysis from this. But the other subgroup analysis that was interesting was sepsis. Okay, so in sepsis in patients, early use of albumin was actually better than that of saline, and so that this was about 1,000 patients which they did subgroup analysis on, and interestingly enough, early like I said, it was a pretty strong signal here that early albumin was probably better off than saline was in that context. Now, around the same time, there were two studies coming out. This was done in Scandinavian countries. I believe the first one was in Finland and the other one was in Norway and Sweden. But where it kind of looked at hydroxyethyl starch, one of the other colloids that was there, versus Ringer's lactate, versus one was with saline and the other one was with Ringer's lactate. So when hydroxyethyl starch was studied against saline, there was no real difference in outcomes and mortality up to 90 days of randomization. But when you did that against Ringer's lactate, it was interesting because Ringer's lactate was there was a divergence in mortality somewhere around like day 12 or 20, 12 or 15, and then that remained clinically significant up to 90 days as well. So it's interesting because you're using the same set of population of patients, but now you're starting to see that there is a difference in outcomes between what fluid is actually used. And so you could actually ask, well, what is the difference between saline and Ringer's lactate? Well, so here the difference was the hydroxyethyl starch, the carrier for it was saline in both the studies. So you're sort of comparing saline versus saline. And so one of the thoughts was this is saline versus saline. So that's why it was not that different. When you start doing saline versus Ringer's lactate, there is an actual difference in mortality showing up. So now you're starting to see the difference. Now you're starting to see that, okay, first albumin and saline were same. Now you're starting to see like saline and Ringer's lactate, there might be a differentials in mortality, or it depends, or it may just be that different populations require different thought process about how we give fluids. This is not misspelled. This is actually the Crystal trial, randomized trial. So it was a 57 center international ICUs for, it was almost like a 9-10 year trial where 7,000 patients were looked at. They were looked at colloids versus crystalloids in general. And they used multiple types of it to look for except maintenance fluid, all other interventions were, if you were in the colloid arm, you kept staying in the colloid arm. If you're in the crystalloid arm, you kept staying in the crystalloid arm and did that. The study was interesting in the fact that it showed like it did not, none of the other outcomes were actually significant. There was no difference in mechanical ventilation or renal replacement therapies and things like that. But the mortality at 90-day was actually significantly different between colloids and crystalloids, and it was favoring colloids. Okay, so it was interesting, but when you actually dug down further into the study, that's when you sort of realize that all of the effect was actually driven by one subgroup. It was between the hydroxyethyl starch versus isotonic staining. Everything else was not significant versus it. So if you were to actually go back, right, this is essentially a different version of the same study that ended up happening. That was published in New England Journal, but in a different patient population now that you're starting to see it. Okay, so just using what we have now, going back to our case. So what we ended up doing was they gave 2 liters of saline and then 2 more because his IVC was collapsing greater than 30% on an intubated patient. So now, you know, as a standard CMS-driven standard of care with the sepsis protocols that are there, you know, repeat BMP at 4 hours actually showed to see the lactate clearance. The lactate was clearing, but the chloride actually went from, if you remember, the original slide was 100, has now come up to 114, and the vitals are starting to look better too. But let's talk a little bit about the chloride that we gave from the saline. Is that okay, right? And so this is all like a lot of the studies that I'm pointing out are in the 2000 to 2010 in that decade, because there was a lot of studies that came about saline at that time to start wondering about how do we use saline in different not saline, I should not say, I'm sorry, I should say crystalloids at that time, or IV fluids, colloids and crystalloids in that time, about like how do we actually use different fluids in different scenarios. So this is an animal model where they actually took rats, about 30 rats, and injected them with E. coli toxin to cause them to go into septic shock. And then they were resuscitated with either saline or hextan, and they sort of tried to look at the outcomes between them. So the mean survival here is in minutes. There was a clear difference where hextan was better than the saline part. So, but when they actually looked at it in terms of relationship to chloride, you start to see that there is an actual the change in chloride, the more the change in chloride there was, the faster or the faster they died or worse their outcomes. They also measured in a different part of the same study. They also measured markers like IL-6, IL-10, and TNF, which we know are associated with like the more severe forms of sepsis. And what they started to notice was they all of those markers were starting to climb up as the change in chloride increased. So, and the same, like at least Andrew Shaw was, I think, the author in one of the animal studies, and then they sort of tried to do a database analysis for one of the large data sets that is available from the electronic medical records, and they sort of like retrospectively look back at it. Looking at patients who they could identify with two of the SIRS criteria, and they looked at their outcomes. So what you can start to see is like as your chloride, the change in chloride at 4872 hours starts to go up, your mortality also starts to go up quite dramatically. Actually, goes up. Then they actually stratified it in terms of the time frame as well as the amount of fluid that they were initially given for resuscitation. So what you notice is like more the amount of fluid that is given, and the more the change in chloride that is there, the more the mortality increases. With the exception of this one arm here, where if you gave less than 1500 cc's of fluid, and the chloride actually, like the mortality actually dropped. If it was anything more than 1500, more chloride change, more fluids was actually increased with worst outcomes. So the same authors then followed it up further. When the authors actually followed up, and they it was at that time in the United States, it was hard to distinguish between if you could not you couldn't just give somebody balanced fluids. And so what they tried to do here was they looked at the proportion of balanced fluids versus the proportion of saline, and started to notice that the more the proportion of balanced fluids that was there, the absolute mortality kept dropping. And that was an interesting finding that showed up there. So far, what I've shown you, despite the technical difficulties, is there's no original basis for saline, but there's no so initially what was thought to be no real differences between colloids and crystalloids for initial resuscitation, but now you're starting to see that there might be some difference. Although albumin, like kind of said, like may have some benefit in early part of shock. Increasing levels of chloride now are starting to show that there might be worse outcomes. Okay. So I've said a few things about balanced fluids, right? Like, so let's talk a little bit about balanced fluids now. In general, balanced fluids are the reason they're called balanced is the pH is closer to normal. They have less chloride and less sodium, and they sort of look like your chemistries. If you were to draw a basic metabolic panel for a normal person, they are trying to mimic that as close as possible. That's why it's called balanced. Okay. So surgical literature actually was a little bit ahead of medical literature at this time, which is an interesting thing to say. But like the surgeons were actually noticing some of the stuff earlier too. So these are two studies. One is the saline versus plasma light in resuscitation of trauma patients. So it was a randomized trial of about 100 patients, where what they noticed was the base excess was different. The pH got to normal much faster. The chloride loads and the magnesium loads were significantly different too. So all in like starting to show that maybe balanced fluids is the way to go. So the follow-ups, another study with around the same time was looking at a database again of open abdominal surgeries, and where they found that the ventilator use was actually lower in patients who got balanced fluids. So and again, this is not just so we're clear. Some of this, and I'll come back to this point later. You look for signals for research in retrospective studies in like animal models and things, and then that's how you sort of build up your research, right? Like there's an idea, somebody goes hunting in charts, and then you come up with some hypothesis, you get some data for it, then you get grants and all to do is maybe some animal models, and maybe if that's successful or shows that there might be more, you sort of progress towards RCTs. And so, as you will notice in this talk, a lot of this was initially was what was thought to be there, looking at a lot of retrospective data, and we're coming to some of the randomized control trials in a minute too. Okay, so this started to show that fluids, like balanced fluids, might be better because they did receive less blood transfusion, and this was an interesting finding that was there. Lesser ABGs was there, and they resuscitated faster. So if you look at the part about it, there was not much difference with the exception of like a major infection in surgery was somehow less, and that wasn't quite understood why that was happening. So a different study, this was just in SIRS, again, similar database analysis, large hospital data sets, about 700,000 patients were there on it. There was more in-hospital mortality with saline compared to balanced fluids, and the length of stay was slightly different. In the United States, like the length of stay matters a lot, and so some of the studies focus on a lot on that as well too. And so that was starting to be different as well too. So some signal to say like maybe saline is not the best choice. Also, all of this led to this seminal sort of landmark trial that was published in 2018 out of Vanderbilt, which showed like it was the SALT trial and the SALT-ED trial, as you want to, if you want to search for it. It was balanced crystalloids versus saline in critically ill adult population, and this was a large cluster randomized multi crossover trial of 15,000 patients in 5 ICUs. Now, it's 5 ICUs, but they were technically in the same center, like in the same the system, if you will, that was there, where they looked at balanced crystalloids versus saline, and the composite outcome was actually better, meaning composite outcome of death versus and renal replacement therapy or renal dysfunction was better with balanced fluids than it was with saline. Now, again, all of the stuff that I've been sort of pointing out to you has sort of finally culminated in the first, like a real. I mean, there were a few other RCTs there, but none were done as rigorously as this one was done. And so now you have the first clear like a RCT. Now, I just want to point out this was not a blinded study. And I think that's an important fact to sort of keep in mind. One other thing that I do think that is relevant for this, and this will come up in a little bit too, is like when you looked at the balanced fluids. Now, the balanced fluids that they included were not just plasmolite or isolite that is there. They also considered lactated ringers as a balanced fluid, and a majority of the balanced fluids patients in this trial were if memory serves correctly, it was about like 60 or 70% of the patients were actually had LR given to them as part of the study. Now, a couple of other things. Now, characteristically wise, about the 7,000 versus 7,000, the patient population was mostly similar across the board. A couple of things I want to point out is like the number of mechanically ventilated patients in this trial was about 30% in each arm. And the pressors were about 26% in each arm. But otherwise, the outcomes we talked about, the composite outcome of survival was actually significantly different. So this group actually did the study in a twofold way. What they did was they looked at resuscitation for critically ill patients in the ICU, but they also looked at non-ICU or non-critically ill patients who never made it to the ICUs, because they did it as a blanket in across their hospitals, and so they got two sets of data to sort of work with. So this was also a pragmatic trial that was there, 13,000 patients in it. And in this trial, which on patients which did not hit the critical care doors, there was no difference in outcomes between the balance versus a saline that was there. So Obviously, these two trials left a lot of questions about, like, and especially because the thought was like, is it the LR that's doing it? Is it saline that's doing it? Is it the balanced fluids that is doing it? And so there was a lot of talk about, like, well, is actually plasma-light the superior fluid that is there? So this ended up in this recently published New England Journal trial where there was balanced multi-electrolyte solution versus saline, which here you, when they say multi-electrolyte, it's things like plasmalite, which have multiple electrolytes in it, or isolite, which have multiple electrolytes in it. So it was a double-blinded randomized trial of 5,000 patients in 53 ICUs. And in this, as you can see in the Kaplan-Meier curve, those Kaplan-Meier curves are literally the same throughout the course. Now, if you look at the subgroup analysis also, there is slight deviation one way versus the other, but overall, there is no real difference across the board. Some have argued that, okay, look, in the higher Apache score, maybe there is some signal that this might actually be balanced fluids might be better, but overall, there was no evidence of increased death or renal replacement therapy or kidney injury associated with saline versus balanced fluids. Now, there is difference in the set of patient populations here, because if you'll notice that the invasive mechanical ventilation in this patient population was 75%. So these were primarily intubated patients that were there, and they were higher incidence, higher pressor usage too. So inherently, the patient population that was used in this trial, like the balanced fluid trial versus the original salt trial, was different, right? Because you're using less mechanical ventilated, less pressors. These are much more mechanically ventilated and more pressors in this trial. So that raised the question of whether there might be patient selection or something else that is there. So as what happens in medicine, so now we have done signals from anecdote, like signals from case series. We have gone to retrospective database analysis, to animal models, to now RCTs, now double-blinded RCTs. The evidence has changed across, as we have sort of pointed it out. So what that leads us to, then the last part about it is a meta-analysis. So looking at just when the study started to come out, another group quickly did a meta-analysis on the evidence that was available. So they looked at 13 trials comprising about 36,000 patients between balanced crystalloids and saline, where they used the 90-day mortality as a primary outcomes. So the interesting part is, so they did two-way analysis on this. One was a Bayesian way, and the other was a frequentist method of doing it. I am not qualified enough to explain to you in great detail about the differences between the two outcomes, but suffice it to say, what they found was mostly there is no significant difference between the outcomes of the fluids. What they did mention is, like, when you do the Bayesian analysis, is the estimated effect of using balanced fluids versus saline in critically ill showed that there might be a 9% reduction in mortality. There is a chance that there could be a 1% increase in mortality as well too, with a high probability that it's closer to the 9% reduction in mortality. And so the author sort of came to this conclusion, where I will also leave you with that in what the conclusion in a second. But if you look at it, no real differences in kidney injuries or failures or vasopressor usage. But the evidence level was high, but like it depends on some of these aspects of it. The evidence level is not as great, like whether you need renal replacement therapy or not, or so that part is not there. But the vasopressor part was there. So, I mean, if you actually effectively resuscitate your patients, the likelihood of being on vasopressor or reduction in vasopressor was high. So the discussion is interesting because where it talks about, and I said this at the start of talk, right? Like how you resuscitate or fluids used in the ICU is based on at least two different things: the type of fluid that you use, and also how are you using it and what rate are you using it. Like those things also matter. Now, these those were not actually looked at, is what they're saying. And so there is a fundamental difference in how some of this is being used. Okay. So I'll leave you with the final few things, which is, look, individual characteristics matter, right? Like, so what the patient is going through actually matters in what fluid you actually end up giving them. Cost and availability absolutely play a huge part about it. I worked in institutions where, they were blatantly, we are not going to do one fluid versus the other because of cost purposes. And sometimes they didn't have it available. So that all of those things actually matter. Now, balanced fluids may confer benefits in special populations such as DKA because you're getting your electrolytes fixed much faster. Or in certain populations, it may not be actually be helpful, right? And so those things, all of those things matter. So the point is, if you actually sort of summarize this talk in like a few slides, I mean, you should use the same caution when you're trying to decide your fluids as you would when you're giving any other IV medication. We should think about fluids just as way you would think about IV meds, like when your choice of pressors, or how one pressor does not fit all. It's the same concept. Like one fluid does not fit all, and you have to sort of use the various patient factors that are there in time trying to decide what fluid to give and what physiological processes are going on. Fluid requirements changes over time, and so should your fluid. So should the type of fluid that you're giving also should change over time. There are cases where patients are coming in, you're giving them saline up front, and then because they're also hyponatremic and they may have like traumatic injury and stuff like that, and so you're giving saline up front, and then like later on in the course of the time when you see their chemistries have come to a certain point, it might be worth considering to change your fluid selection at that point to balance versus not, and vice versa. Things can happen too. So there are specific populations where you have to use fluids differently. So if you remember when I talked about the SAFE trial, I pointed out that albumin is not something that should be ever used in a traumatic brain injury because there was data around that which said like they had worse outcomes from it. So uh, I said in the beginning, like this is like even though studies have come out after this, the concept in this one slide from the 2013 New England Journal paper on resuscitation actually is fairly reasonable and solid for us to think about. I kind of mentioned it, like, think about your patient, think about what is available, think about what is the cost, think about what is it that you're trying to do, and also some of the patient characteristics. Like, for example, and I kind of mentioned this, albumin not in traumatic injury, but you could use albumin if you had it and there in early severe sepsis. That might be a good place to do it. When I say early, but then it's also like then realizing that you could switch over to other things there. We didn't talk about this. One of the other reasons why the Scandinavian studies, what they actually ended up pointing out a little bit was that they had higher bleeding complications associated with it, and so some of the hydroxyethyl starch type of fluid or HESPAN type of fluids actually fell out of favor because of that. But that was the other byproduct of the Scandinavian studies. Um, if you have saline is probably a good thing for patients with alkalosis and hypovolemia. So think about if that's what your patient is coming in with, that might be a reasonable approach to do it as well too. So look at your patient population, see and then decide. Don't just take one fluid and sort of run with that. Uh, and so to quote 007, and I think this is probably the crux of the entire talk. It's choose your resuscitation fluid wisely. Um, that's all I have. Thank you so much. I'm happy to take questions. And sorry about the technical problems that were there in the middle.